Hello guys, a very good evening, good afternoon. So today we are going to have a PYQ Marathon. So where I am going to discuss only the previous year questions, and we'll discuss something which might be useful for us. We are going to have a very quick session where I am going to discuss many questions like David, we have started, fine. Okay. I hope I'm visible and audible. Okay, fine. So like the PYQs of the NEET INA. So it'll be like quick session. I'm restarting. I'm trying to stream it again. I don't know. There must have been some disturbances in the OBS. Is it okay? I think it's fine now. Okay, great. So we'll start from first again. Sorry for the glitch which happened, right? So I hope the internet is fine and the video is fine as well. Fine. So what I was saying is we are going to see today the entire PYQs. So it's going to be, I'm going to display a question. I want everyone who's online here to comment, and we'll have 1 or 2 points relevant to the question so that it'll be much easier for you to, because you have 1 month left and I hope your exam will happen on time. So it'll be easier for you to know what are the topics which have been asked in the previous exams, be it INACT or NEET or FMG exam, and you can learn as per that, right? And I hope you have registered this test, which is live tomorrow. We'll make sure there will be no errors. We are looking forward to the test and we are looking forward to feedback as well. So do give the test, and whatever plans you want, you can enroll with any coupon you have, or if you don't have a code, you can use my code PathoCups, fine. So let's start. So this is the first question. I'm going to display a question and I'm going to wait for 30 seconds. I want everyone here to answer. Since it's an easy question, please do answer, right? And I'll be asking leading questions towards that. That also I want you to answer. What's your answer to this? It's a very simple one. I want you guys to answer. Okay, Jeevita has gone with B. Arjun has gone with B as well. Fine, it's a very simple one, right? I want everyone who's online here to answer. It's fine, that will break your barrier of inhibition. Okay, the common answer is going to be B for us, right? A 65-year-old person diagnosed with a case of a lung carcinoma, and the patient has a paraneoplastic syndrome of increased calcium. So hypercalcemia is definitely one of the commonest paraneoplastic syndromes seen in lung cancers, right? If I can ask a leading question, tell me what subtype of lung cancer you will see this. Like, is it adeno, squamous, or small cell carcinoma? Which subtype of lung cancer hypercalcemia is more common? Great, it is more common in squamous cell carcinomas, right? So in case of squamous cell carcinomas, adenocarcinoma, your paraneoplastic syndrome of hypercalcemia is definitely more common, and it is due to your increase in parathyroid related peptides, right? It's not directly parathyroid, it's parathyroid related peptide which can cause the same thing, fine. If I have to talk about one paraneoplastic syndrome which is with relevance to your small cell carcinoma, can anyone name at least one paraneoplastic syndrome in relation with small cell carcinoma of lung? You know the answer. There are 2 of them. There are 2 common paraneoplastic syndrome which can happen. Okay, it's Cushing's as well as SAADH, right? Do remember them. Syndrome of inappropriate ADH secretion and Cushing syndrome. These are 2 common paraneoplastic syndrome which can be seen in small cell carcinoma of the lung, right? Lambert-Eaton as well. Yes, great. Yes, I said it. Fine. Okay, fine. So these are few things regarding your paraneoplastic syndrome in relation with lung carcinoma. Lung carcinoma again is an important topic which keeps repetitively coming in relation with pathology. There was a PYQ which determined the difference between, you must have read about 3 tumors in your neuroendocrine origin, your carcinoid, atypical carcinoid, and small cell carcinoma, right? All these are your neuroendocrine lesions, right? So there was one question which was based on the criteria of difference between carcinoid, atypical carcinoid, and small cell carcinoma. I'll give you a clue. You have a biopsy which says your mitotic count is 6/10 high power field and there's no necrosis and no nesting pattern. What will be the diagnosis? Carcinoid or atypical carcinoid or small cell carcinoma? Where it will fall into? Tumor with mitotic count of 6/10 high power field, no necrosis, no nesting pattern. Perfect, that will come under atypical carcinoma, right? Just remember this, 2 to 10 mitosis per hyperfield, it's going to be in your atypical carcinoid. If it is less than 2 mitosis, it goes to a typical carcinoid, and greater than 10 mitosis, it goes to your small cell carcinoma, right, Abhishek? Yes, I said it in Abhishek. Yes, you are right. It comes under atypical carcinoma, right? So we read few things regarding lung carcinoma and this question, right? So we're going to do the same thing. You're going to comment on the answer. Again, everyone should comment on the answer. It's fine if you make a mistake here. The exam is just 20 days on the road. These mistakes, what you make here, will not reflect in a real exam, right? Okay. Look at the question and comment on it. I'll mute myself for 30 seconds. Comment on whatever comes to your mind. I want you guys to comment on two things. One, come to the diagnosis and then also the answer. This is an FMG repeat. It is a good question. Go ahead. Okay, I'll highlight the important points here. You have a central bronchiectasis, atelectasis of the chest. There is no vas deferens, that's an important thing. And I have plenty of nasal polyps. So Abhishek has given us a starting point. He has commented on cystic fibrosis. Do you guys agree that the diagnosis here will be cystic fibrosis? I'll just go with the diagnosis alone first. My diagnosis is definitely cystic fibrosis, right? Recurrent sinusitis, polyps, bronchiectasis, and this is very, very important. Absence of vas deferens is like classical finding for cystic fibrosis, right? So diagnosis cystic fibrosis, right? I know why you guys are not answering the question, right? Because if it is cystic fibrosis, now you guys will answer. What is the defect in cystic fibrosis? The defect is sodium channel or chloride channel or potassium channel. The defect is chloride channel, right? So I don't have anything chloride channel here. I'm sure you know that it's CFTR, it's chloride channel, right? So it's a chloride channel defect, but I don't have any options of chloride channel here, right? So that's the reason there's a little bit of inhibition from most of you guys why I don't have anything. It cannot be an immotile cilia syndrome because an immotile cilia syndrome is cartilaginous syndrome. Cartilaginous syndrome, vas deferens will absolutely be normal. Since there is an absence of vas deferens, it cannot be an cartilaginous syndrome, right? It's not a potassium channel. It's not a sodium channel as well. Like you guys commented, it's a chloride channel defect, right? So it's a chloride channel defect. Can I say a chloride channel is also a protein? That's also a protein, right? Enzyme is also a protein. Anything in my body is going to be made of protein. So if you have a mutation which is due to a defect in the truncation of the protein, which means protein misfolded defect, can it cause cystic fibrosis? To be specific, the misfolded defect of chlorine, the chloride channel, can that cause cystic fibrosis? Yes, that can cause cystic fibrosis. This is a case of cystic fibrosis. This is not cartilaginous because cartilaginous will have infertility but not absence of vas deferens, right? So this is an important clue here. So this was a question which came in FMG exam. It was a bit on the difficult side, right? So if you miss that point, you might think of cartilaginous, you will go with cartilaginous. So it's an indirect link. Your diagnosis of cystic fibrosis is correct, but it's a defective truncated protein, right? Just to substantiate this finding, this is what you must have seen in your Robbins, right? I have 6 different types of cystic fibrosis. You need not read all 6. I'm just going to tell you 2 things from this flowchart, right? First thing, if you look at it, there's a truncated protein. You can read there, it's written an unstable truncated RNA or a protein misfolded defect. So truncation will definitely cause a problem in cystic fibrosis, right? So it will definitely cause. Type 1 and type 2, these both are going to be very severe. These are very severe form. Type 3 to 6, everything are less severe. Okay? Because in type 1 and 2, you'll have like complete destruction. I won't have any little molecule of CFTR. 3 to 6, it will be reduced. Even if you look at the image, here also I don't have any CFTR, no CFTR, but here I do have CFTR, the chloride channel, but there's a little bit of defective, right? Okay, I'll ask you a leading question. This I am sure most of you will answer. I'll come to it, just give me a second, right? So here, okay, the question I was about to ask is, what is the most common mutation you see in cystic fibrosis? What's the most common mutation you see in cystic fibrosis? the most common mutation? It's delta F508, right? The delta F508 comes here. It's a class 2 type, right? It's deletion of phenylalanine in your 508 codon. That's the most common mutation, and that comes under class 2. Fine. I'll take, as I said, its question, why no diarrhea in cystic fibrosis? Actually, cystic fibrosis has a very, very interesting history. If you look at the history of cystic fibrosis, what happens is, again, I want help from you. Cystic fibrosis is a disease common in our country, or it's common in Caucasian population? Where is this disease common? India or abroad? It's definitely a disease which is very, very common in the Caucasian population. It's not a disease which is common in India. It's a very rare condition in India, right? The reason why this disease is more common in Caucasian population is I have to revisit history for that, right? In your microbiology, have you heard about this? Where have you heard about this? LTOR. Where have you heard about LTOR? Which microorganism, to be specific? You must have read about this in Vibrios, right? So you must have read about Vibrios, LTOR Vibrios, and other different types of Vibrio cholera, right? So in the same microbiology textbook, you also must have read about your pandemics of cholera. Cholera is one of the bacteria which had pandemics, right? So can I say, I think the last pandemic is 7th pandemic of cholera. I'm not exactly sure about the number. The 7th pandemic of cholera happened in and around the Caucasian population in Europe. So what happened is, in Europe, there were like n number of people dying because of cholera. Like COVID was there and we are dying because of COVID. So can I say, my body will definitely do something to escape the action of cholera? They will. How does cholera toxin act? Can I say they act on activation of CFTR or the chloride channel? Cholera toxin acts that way, right? The cholera toxin acts by activating the chloride channel. Yes, that's how they act. So in that case, if my body can develop a mechanism and inactivate the chloride channel, will that stop cholera? It will stop cholera, right? Human beings are the best medicine. I didn't have any way to treat cholera pandemic, so my body automatically had a mutation in the chloride channel. So that causes this, right? Right? Perfect. So now, yes, I said it. Coming back to your question, actually the CFTR will act the opposite way. CFTR is not going to cause diarrhea. CFTR will act the opposite way, reducing the amount of fluid in the intestine. So if reduces the amount of fluid in the intestine, will it cause diarrhea or will it cause impaction? Yes, Chakravarti, similar to sickle cell trait in Africa. So if CFTR reduces the water content of the feces, will it cause impaction or diarrhea? It will cause impaction, right? I'm sure you must have read this. Have you read this as one of the features of cystic fibrosis? Meconium ileus. Meconium ileus is one of the classical features of cystic fibrosis in an infancy, right? So during infancy time, yes, if it causes a very thick thing, I can cause an impaction. So cystic fibrosis is not related with diarrhea. It is related with the opposite one, impaction, right? I hope that answers it out. Okay. Again, a very simple PYQ. I want everyone to answer. It's a simple one. Simple ones you have to answer. 30 seconds, I'll mute. Okay, great. It's a very simple one, right? Disease with bulky, friable cardiac vegetations, right? Again, cardiac vegetations has been an important topic for PYQs. So nearing the exam, do read this topic at least in close to exam, fine? Okay. So it's a classical case of infectious endocarditis. Again, I'm going to ask leading questions regarding vegetations. I want you to answer whatever comes to mind. The only infective vegetations in the heart. These are the only 4 causes of vegetations, right? The same 4 causes, we'll look at different permutation combinations. The only infective vegetation in the heart, it is infective endocarditis, right? Perfect. Second, the only vegetation which can be seen on the atrial side of the leaflet and the ventricular side of the leaflet, on both the sides, which is, if I have a leaflet like this, atria and ventricle, there's only vegetation which can be seen on both the sides. Which vegetation is that? Perfect. That's Lippmann sex endocarditis, right? Great. So you have one vegetation of these four. We call them as verrucae. Which of these are the tiniest vegetation which can be called as verrucae? Both sides Lippmann, which is called as verrucae. Rheumatic carditis is called as verrucae, right? So rheumatic vegetations are called as verrucae because they are very, very tiny, like Verruca vulgaris of an what, right? If I take rheumatic carditis induced vegetations, are they sterile or do they have organisms? It's seen secondary to a streptococcus infection. The rheumatic carditis vegetation is sterile or has organisms in them. They are absolutely sterile. The vegetation is due to the antigen antibody immune mediated reaction. It's not infective, right? Non-bacterial infective thrombotic endocarditis, NBT. These vegetations, are they sterile or infective? That's also sterile, right? So if I'm going to take a microscopy of an NBT, what will you see in microscopy? What will you see in microscopy of NBT? You know the answer. You're going to answer the answer. Everything is there in the name. NBT, what I see in the microscopy. Just the other name is Marantic, understood. What do you see in microscopy? You answered so many things. Just complete this, it will complete it. NBT is not subacute bacterial endocarditis. Yes, I said it. NBT is, as the name says, expand NBT. Perfect, right? Thrombus. Good. I'll see fibrin thrombi. It's non-bacterial thrombotic endocarditis. So in microscopy, I'm going to see fibrin and it's perfect thrombus, right? Okay. Subacute bacterial endocarditis also will go under infectious only, fine. This is what I'm going to see in microscopy, fine. Just one last question regarding endocarditis that will complete most of the things. One example of NBT. You just now said it's thrombus. So just give me only one example of NBT. Anything which comes to your mind. NBT, one example, it's thrombus. So tell me one example. Give me any example of any disease which causes thrombus inside the body. It's a very, very simple one. You know one thing. Cancer will cause it. Like Chakravarti and Desi said, cancer will cause it. Won't DAC cause it? DAC is disseminated intravascular coagulation. Will I have thrombus in the valve as well? I will, right? So any disease which can cause thrombus formation, right from your APML, your mucinous carcinoma, pancreatic carcinoma, your Trousseau syndrome, DIC, it will cause, your Apla syndrome, it will cause. So any cause of intravascular coagulation can cause NBT, right? Just remember that, fine. Okay. This is an image from Robbins, both sides of the valve. NBT is again on the leaflet, little bit bigger. Rheumatic heart is very, very tiny, just on the surface of leaflet again. This is the only thing which is destructive and can destroy the valve as well, fine. Okay, next. Look at the image and comment on the answer. Okay, in 30 seconds, I'll not speak. I'll give you a clue. This gland is sebaceous gland. Okay, great, good. I want more guys to answer. This is like a final response. You're going to answer whatever comes to your mind, right? So the microscopy, like I said, you have sebaceous gland there. Sebaceous gland is obviously an holocrine gland, right? So I'll give you a description of a gland. You tell me where it will fit into, apocrine or a holocrine or a merocrine. Okay, I'm having a gland where the secretions of the gland are secreted into the ducts without destruction of any part of the cell. Merocrine, apocrine or holocrine. Secretion directly goes to the duct. They are just like secreted without any destruction. There's no destruction of the cell or any part of the cell. there's no destruction of a cell, that will be merocrine, right? In apocrine, what happens is the apical part of the cell will be destroyed, right? So what happens in apocrine is you'll have a cell like this. If this is a normal cell, once it secretes, it will pinch off like this, right? So when an apical part of a cell destroys, that will go into apocrine. That's what an apocrine means, right? So give me only one example of an apocrine gland. Any one example what comes to your mind of an apocrine gland? The tip breaks of an apocrine, correct? One example of apocrine gland. Any example? Sweat gland. Not every sweat gland is apocrine, right? Sweat gland is correct, but there is one particular type of sweat gland which can be apocrine. There are two examples of apocrine glands. You should know that sweat gland in your axilla and perineum is apocrine. Not all the sweat glands. And there is one more, mammary glands. Great, right? So I'm going to take whatever Abhishek said. So I'm going to have a mammary gland. So mammary gland, can I say they secrete both milk and protein? Is that true? A mammary gland can secrete both milk and protein, right? So if that is true, there are two secretions. Which of these two is apocrine mediated? Milk or protein? Which is apocrine mediated? Milk or protein? Only milk secretion is apocrine mediated, right? So if you look at this table, this is a very good table. Your mammary protein secretion is merocrine. Keep this in mind. And only milk secretion of the mammocrine is apocrine, right? Protein secretion will be in the form of merocrine and the milk will be apocrine. So if you have a question in the exam, please read what they are asking. If it's a milk secretion, it has to go into apocrine type of gland. If it's a protein secretion, it has to go to merocrine type of glands, fine? And sebaceous gland is holocrine, where the entire cell gets destroyed and everything comes outside, fine? Okay, next. Comment on the answer. Again, 30 seconds. Read the question properly and comment. I want everyone to comment. You know the answer, do comment. We'll read more together, medicine level. Answer? Okay, brick red D. Okay, great. So it's okay. Few leading questions regarding the staining, right? It's triphenyl tetrasodium chloride, TTC staining in the heart, right? Great. So this staining technique is a gross methodology or a microscopic methodology? That's my first question. This is gross methodology or it's a microscopic methodology? It's a pure thing which is done on gross, right? It's not a microscopic staining technique. Perfect. So what I do here is, once a person's autopsy heart is done, taken, you cut the slice of the heart, pour the triphenyl tetrasodium chloride and look for the color change. If I'm going to have a color, there are three different possibilities color. If you have a color which is extremely whitish, that can be a possibility. Pale can be other possibility. And like you have red or brick red, that could be a third possibility, right? What will happen? What is the interpretation if it is extremely whitish in color on a gross? There are only three possible colors and we have to look at all the three possible colors. Extremely white color possibilities. White is not infarction. Pale will be infarction. Extremely whitish, again not normal. If it's extremely white, it has to be scar, right? It's scar tissue. Great. If it's pale, yes, I can call it infarct, right? Normal heart will be red in color, right? So just keep this in mind. It could be a chronic infarct or a scar tissue, whatever you want to call it, you can call it, fine. Okay, this is an image from Robbins. It has all the three colors. What is this? I'll mark 1. Let's assume this is 2. Let's assume this is 3. What do you think 3 is? What do you think 3 is? 3 is the scar tissue, right? That's an old infarct. The first one is pale, which is a normal infarcted myocardium. The second one is completely normal myocardium. The third one, which is looking extremely whitish, is a scar tissue, right? So all three are important. Again, interpretation is based on what is being asked, white or pale or red color, fine? Okay, great. Read the question. 30 seconds, answer. Okay, go ahead, answer. It's a very classical case, you shouldn't miss it. Great, right, so good. No, fine. So most of you have gone with A. Mohit has gone with a different one, right? So we'll look why it is not the other one. The correct answer here is A, but I have to rule out the other ones also, right? Teratoma and papillary serous cystadenocarcinoma. Both of these two on a gross image, will it be solid or cystic? I don't want any history, I'm just looking at the image alone. Teratoma and dysgerminoma in a solid place. Will it be solid or cystic? Both teratoma and your papillary serous cystadenocarcinoma. It will be cystic, right? So that is enough for me to rule them out, right? So there's a very solid neoplasm which is given in the image, right? This is mature cystic teratoma. Anything which is the term serous will be always cystic appearance only, remember them, right? Both of them are cystic, B and C, so that's totally ruled out, right? And scoliocarcinoma. Can I say scoliocarcinoma will be extremely hemorrhagic? It has to be extremely hemorrhagic, right? Scoliocarcinoma will be hemorrhagic. I don't have any spot of hemorrhage here, so it's not scoliocarcinoma also. This will be extremely hemorrhagic. So the only two colors which I'm going to look for is red or blackish in color. Keep this in mind. If you have something blackish in color on an ovary or a uterus, there are two possibilities I want you to keep it in mind. Both complete red or complete blackish in color. What are the two possibilities if you have an extremely hemorrhagic lesion on an ovarian gross? Completely hemorrhagic ovarian gross, blackish or reddish in color. One, it can be choriocarcinoma. What's the second one? Second one, endometriosis, a good choice. So I want to ask for one more. Chocolate cyst endometriosis also will have the same color. Great. It could be choriocarcinoma. The third one, please do remember this also, torsion. Fine. A torsion of ovary, your chocolate cyst endometriosis, and also our choriocarcinoma. All three of them will have an extremely hemorrhagic area and a blackish area, right? So keep this in mind. Endometriosis, your torsion or your choriocarcinoma is fine. Okay, coming back to this question, it's extremely solid tumor. Dysgerminoma is the only possibility, and the microscopy what you can see is cells with a clear cytoplasm and a little bit of hemorrhage here. Sorry, a little bit of RBCs, WBC, which is lymphocyte there, fine. So I have a little bit of WBC, which is lymphocyte in the septa, and nests of clear cells, that is diagnostic of a dysgerminoma, fine. Okay, the next question. Okay. Let's see if you can answer this. It's a more of fact-based question. I hope you know them. 30 seconds again. Okay, so my question is something called an hypereosinophilic syndrome, right? So actually the right answer for a hypereosinophilic syndrome should be very severe eosinophilia. So we classify eosinophilia as a mild, moderate and severe, right? These are three groups of classification of eosinophilia in general, right? My normal absolute eosinophil count is up to 400. If it is more than 500 till 1500, I call it mild eosinophilia. 1500 till 5000, I call it moderate eosinophilia, and something more than 5000, I call it severe eosinophilia, right? These three are the categorization. When I don't have any end organ damage, I need to have severe eosinophilia to call something as an hypereosinophilic syndrome. But this question documents end organ damage, right? For an end organ damage, I need to have at least more than 1500 to call it an hypereosinophilic syndrome. Ideally, it should be a severe one, which should be more than 5000. Here it is 1500 above with the presence of end organ damage. Still, I can suspect hypereosinophilic syndrome. Fine. More than 500, most of you guys answer yes, that is eosinophilia, but might not be enough to call something as a hypereosinophilic syndrome. Fine. Right. So I'm going to show you an image. This also came in one of the AIIMS exam. Tell me what is A. There are 4 different things marked here. Just we'll try to understand what is which is which. A is this one. What cell is that? Okay, I'll give you two options. Is it a neutrophil or a band form? Is it a neutrophil or a band form? Because I want a specific answer. Okay, Arjun, I said A is the WBC. Is it neutrophil or a band form? It's a band form, right? Band form will be a better answer than a neutrophil, right? Great. Okay, what cell is this? What cell is this? The cell which is circled. Can I say that this is a neutrophil? Yes, this is a mature neutrophil. Whatever is there, the WBC close to A is a band form. You can see the lobes here, this is a neutrophil, right? So what cell is B? I'll circle them so that you don't have a confusion with the RBCs. What cell is B? B is in perfect eosinophil, right? It's in eosinophil. You can see the red color granules, that's an eosinophil. What is C? C? C is the kidney-shaped nuclei. That's your monocyte, right? Great. So the last but not the least, D. D is your lymphocyte, right? So again, these are the normal ones, right? Let's see, there's one cell which is tiny hiding here. Can anyone tell me what cell is this? Half cut, but still you will be able to identify the cell. What cell is that? Can I call them a basophil? The last cell, what we are seeing is a basophil, right? We can see the extremely dark bluish granule. That's how basophil will look, right? So we have seen all the normal WBCs required for us. Let's try to extrapolate something else as well. What do you think this is? What do you think is that? The tiny ones. That's your platelet, right? That's normal platelet. Fine. Okay, so we know the WBC is normal and also we know the platelet, right? One more important thing. This one, the RBC, the central pallor, normal or abnormal? The central pallor of an RBC, normal or abnormal? It's again a completely normal finding, right? Pallor of an RBC is definitely a normal finding, right? So I'll show you one more thing. Look at the RBC which I marked, and I'm going to mark one more RBC, this RBC. The pallor in this RBC which I marked second is a bit different. So what will you call them? What will you name them? If you want to name them, can you name any type of RBC? It also has a pallor, but it's not the oval one or the round central 1/3. It has a little bit of different appearance. That one, this one, this one. How does it look? Can I say it kind of looks like a, that's not a spherocyte. That's not a spherocyte. I do have pallor there. We do have pallor. It's not a spherocyte. How does it look? Can I call it an stomatocyte? Okay. Perfect. That's a stomatocyte. That's how stomatocytes looks. The opening looks like a stoma, right? But this patient is not having stomatocytosis. When you see a stomatocyte, stoma is an opening. So the pallor here, which looks like a stoma, like an opening, it's called as a stomatocyte, right? This doesn't make it hereditary stomatocytosis. We have a disease called stomatocytosis. That's a very artifactual finding. You can see them normally also, not all the RBCs are having the same appearance. If all the RBCs have the same appearance of a rectangular pallor, then I can call it stomatocytosis. Fine. Okay. Okay, we'll go to the next question. Read the question and come to an answer. I hope it's seen. Okay, go ahead. I'll mute myself for some seconds. Okay, D, B, others, any possibilities? B, C. Okay, what I want you to look for is this entire cell. How does it look? That's a question. We have mixed response, but predominant of them are going for B, A. Okay, fine. We'll look at one by one question, and no one commented on A, right? So I'm just going to strike this off. It's not a tubular epithelial cell. So I have three other options: decoy cell, Charcot-Leyden crystals, and hyaline cast, right? Most of you answered option C. Can I say what is decoy cell? In which disease do you see decoy cell? In which disease decoy cells are seen? If I know that, it will be very easy for us to extrapolate to this. Where do you see decoy cells? Decoy cells is a finding seen in, it's not seen in multiple myeloma, it's a finding seen in, okay, quite a few of you answered decoy cells. Can I say it's a finding seen in polyomavirus? It's not a finding seen in renal failure, it's a finding, urine finding seen in a polyomavirus infection, right? That's what we call them a decoy cell. So decoy cell means I'm going to have an intranuclear inclusion in the cell. A virus can affect only a cell, right? So can I say this structure which has been marked is extremely big for a cell? A cell should have been this size, that's all, right? A tiny cell. This is an extremely big structure. So by nature, it cannot be a cell. I'm having some blotch of tissue. It is not a cell, so it's not a decoy cell, right? So how a decoy cell will look is, let's assume there's a cell here. You have a nucleus here. Decoy cell will have an inclusion body. You'll have something like this. Little bit of an inclusion body inside the cell. It's a bluish inclusion body. I cannot draw the blue, so I'm using a red color, right? Decoy is an intranuclear inclusion, which is seen in your polyomavirus. Fine, perfect. So now I have Charcot-Leyden crystals and I have hyaline cast. Okay, where do you commonly see Charcot-Leyden crystals? Charcot-Leyden crystals? What comes to your mind when you think of Charcot-Leyden crystals? You must have seen and you must have heard about Charcot-Leyden crystals. Where do we see them? Asthma, right? Or in conditions where there is more amount of eosinophils. When I have lots of eosinophils, I see Charcot-Leyden crystals there, right? They are crystals. If you see any crystal in your life, a crystal will always have a pointed edge, right? If the edges are pointed, that's a way you can pick up any crystal. Charcot-Leyden crystal also will have a pointed edge only. Sputum microscopy, right? So in a sputum microscopy, I can see Charcot-Leyden crystal. The edges has to be pointed in any crystal. This cell, do I have a pointed edge? Whatever is being marked? I don't have a pointed edge, right? In other words, can I say the cell which has been marked, whatever structure has been marked, it looks like a tubule. It looks like a tube, right? It looks like a tube. So it's a cast of a tube. So it's a hyaline cast, right? Even if you have not seen a hyaline cast, just with the shape and the size, I can easily identify that's a cast, right? So the image shown here is an hyaline cast. There's not a pointed edge at all, right? Most of you guys said in patients with asthma, in sputum microscopy, you will see here Charcot-Leyden crystals. This is a urine microscopy. Can any one of you tell me one disease where in urine microscopy I can appreciate Charcot-Leyden crystals? Anyone? It's a bit of a stretch, but still it's possible. Some of you definitely know that. Or in other words, I want you to tell me which urine, in which condition in urine I'll have lots of eosinophils. Whenever there's more eosinophils, you have charcoal-laden crystals. So in which condition in urine, you have lots of eosinophils? No, giardiasis might not have it. Anything apart from parasite? Parasite is a simple one. Parasite might not have in urine, it might have in the bladder. Anything else apart from that? If you see charcoal-laden crystals in urine microscopy, think of drug-induced interstitial nephritis. Okay, you have to think of this whenever you think about charcoal-laden crystals in urine, right? A drug-induced interstitial nephritis. Just keep this in mind. Okay, fine. These are the different types of cast. I hope you are able to see them. A normal hyaline cast will not have any color. The one which we saw there was a Giemsa stain thing, right? And if you see in hyaline cast, multiple tiny vacuoles, that's an hyaline cast with a fat. Name a condition where you see hyaline cast with a fat. We'll see one conditions for each of the cast here. There are multiple tiny vacuoles here. Any one condition where you see hyaline cast with fat in them. You know that lipiduria. When it's lipiduria, it's only one condition which should come to your mind. Nephrotic syndrome. Any patient with nephrotic syndrome can have lipiduria and they'll have hyaline cast as well, right? Okay, great. So here, hyaline granular cast is completely a normal finding, fine. Cellular cast, it depends on what type of cell it is. If I'm going to say the cellular cast is made of WBC, tell me any one clue. Thank you, as I said it. WBCs in a cast, diagnosis. Any one diagnosis. WBC in a cast, you have to think of pyelonephritis, right? Particularly pyelonephritis, not an UTI. UTI might not have a cast. UTI will have only WBCs. Unless and until the infarction is in the kidney, which is an acute pyelonephritis, I can have WBCs, right? There's one important clue to differentiate UTI versus pyelonephritis, fine? Just last one, a waxy cast. Waxy or a very, okay, where do you see waxy cast? There's one disease where waxy cast is very classical. What disease is that? Waxy cast, perfect. You see them in chronic kidney disease, right? CKD, the entire tubule is dilated and exhausted, so my cast also looks a bit broader and exhausted, fine? Okay, one last cast, then we'll go to the next question. Where do you see a muddy brown cast? Muddy cast or a brown cast? Where do you see them? Where do you see a muddy cast? A muddy cast is seen in acute renal failure, right? It's seen in AKI, acute kidney injury. Any case of an acute tubular necrosis, I'm going to see muddy cast. Kamal, I'll take a question. Why was an hyaline cast seen blue in color, right? A very good question, right? This image, what I have done here is, I think it's most likely a Giemsa stain, fine? In a Giemsa or a PAP stain, I don't have eosin component. So in both in Giemsa or in a PAP stain, I might not have the exact blue, pink color, like what I see in a routine H&E. Hyaline is equal to pink always, but it's in a biopsy in a H&E. In a fluid, I either do Giemsa or your PAP stain. Both of them will not have pink color, fine? Okay, answer? It might look big, but it's definitely an easy one. Okay, diagnosis, great. It's lipid droplets. It's a classical case of 4-year-old with an classical case of a nephrotic syndrome. No inflammatory cells, no red cells, and completely recovers after a course of corticosteroids. I'm going to think of a minimal chin disease, right? And a minimal chin disease, what we expect is a lipid droplets. Just an application of whatever we saw now, right? A nephrotic syndrome, lipid droplets, right? Okay, what are these? What are these? Few more urine microscopy images just to complete whatever we want to read. What are these? We're going to see 3-4 urine microscopic images. I just want you to comment whatever you think. What is this? This is an RBC. That's not your lipid droplets. Lipid droplets will not be uniform in size. That's an RBC. More or less everything here is uniform, right? The only difference between lipid droplets and an RBC is, if it is lipid droplets, I'll have one big, one small, like this. It will not be uniform, right? The way a lipid droplet will look is, have you ever seen oil floating on a water? You must have seen oil floating on water, right? Sometimes, right? That's how lipid droplet looks. The urine is like water and the lipid is oil. So it's not having the same structure, right? If you have lots of them with same size, it's going to be RBCs. Different size, you'll have this, fine? Okay, great. Next thing, what do you think this is? What do you think this is? Can I call these also as RBCs? Is that possible? Do they look like RBCs? Okay, great. Bite cells, fine. So Deepthi Mahi, Neha, Shubham. So all of you have commented bite cell or an acanthocyte or a burr cell. So one thing which we can commonly agree is they are not normal RBCs, right? They are definitely something looking abnormal. Is that right? That's what your interpretation is, right? So can I call these, instead of naming them, can I call them dysmorphic RBCs? Yes? If that's true, in which condition do you see dysmorphic RBCs? This urine microscopy, all the images what we are seeing. Dysmorphic RBCs is equivalent to glomerulonephritis, right? Wherever you see glomerulonephritis, if the bleeding is from the glomerulus, I'll have dysmorphic RBCs, fine? Okay, that's how you interpret a normal. I'm just going up just for us to compare. Normal RBC, which is smooth. This is dysmorphic RBC. The bleeding comes from the glomerulus. You should be able to differentiate them even if it's as in a microscopy. Theory wise, you know that. Microscopy also, you know this, right? Yes, perfect. It's seen in nephritic syndrome, right? Okay, comment on these. Again, for a comparison, these guys are RBCs. So comment on the cells which are marked in by red arrows. The ones which are marked by red arrows, one thing which I can say is they are bigger than RBCs. Yes. Perfect. That's our WBC, right? That's WBC, right? So these are WBCs. You will not see the exact nucleus of a WBC because this is not a stain smear. It looks a little bit hazy, right? That's how a WBC looks. Those are neutrophils to be specific, fine? Great. Okay. This I'm sure everyone will jump into an answer. What is this? What do you think this is? The classical finding, everyone knows that. What crystal is this? It looks like a coffin lid shaped crystal, right? Coffin lid is a classical finding seen in struvite calculi, right? It's a classical finding seen in struvite calculi. Okay, I'll answer your question mednomic. Just give me a second. What is this? There's one more crystal in the background. What crystal do you think that is? The background crystal, that's your envelope shaped crystal, a normal calcium oxalate crystal, right? Perfect, great. So mednomic, you had a question that how do I know it's a WBC if I don't have an RBC, right? See, once what happens is, if you see WBCs in the urine, can I say that there'll be a symptom suggestive of UTI? I should have some etiology, right? So the history will be there. In an MCQ, no one is going to just give you a urine microscopy alone. You have a history of burning micturition, maybe a little bit frequency or pain associated with micturition, And then in a urine microscopy, you have an hazy urine with microscopy as cells like this. You can easily extrapolate and say that's a WBC, right? And if you want to look at it, the cell has some inner architecture which is not appreciated. That's how WBC looks, fine. You'll have a history. Even if you look at this question, we had a history of nephrotic syndrome. Then I am looking for your microscopic lipid deposits. It will always have a history. You're going to look at the history, then you can easily come to a conclusion, fine. Okay, this is the most famous question. Answer, 20 seconds. I'll keep quiet. This is a simple one. I thought most of you guys will answer this. The CK7, CK20, you must have known that, right? Okay, Mednomic, answer, comment again, whatever you commented, you are right. Don't remove something just because you are scared. It's completely fine if you are wrong, fine? Okay, you have a CK20 positivity and CK7 negativity, which is suggestive of an colonic carcinoma only, right? The primary here is colorectal. Ovary will not have that. Pancreas again will not be CK20 positive, and breast again will not be CK20 positive. It's in colon carcinoma. That's a diagnosis here, fine. This is a chart from Harrison. You need not read everything here. I'll point out things which you have to read. Before that, it's okay, man. Before that, I want you to just remember one thing alone. Any tumor which comes from the upper aerodigestive tract, upper GIT and upper aerodigestive tract will be CK7 positive. Can I say lung is upper aerodigestive? Thyroid is, salivary gland is, all these are upper aerodigestive, right? That will be CK7 positive, fine. CK20 is lower GIT, colorectal. Remember these. It's a very exhaustive list. I don't want you to remember everything, fine. Your esophageal carcinoma will also be upper aerodigestive. That will be positive for CK7, fine. CK20, Merkel cell carcinoma, though it's a neuroendocrine tumor, unrelated, that's also positive. Both negative, I want you to remember these two alone. Renal cell carcinoma and prostatic carcinoma will be both negative because that will be important for me for diagnosis. When it comes to both positive, again I want you to remember this person alone, urothelial malignancy, right? Other things might not be always important. I'll tell why it is not important. When you take ovary, pancreas and cholangio in this, look here, again I'll have cholangio, I'll have pancreas. It's not consistent. It keeps wavering, so we'll ignore that for some time. Sometimes you can have only CK20 positive in ovarian mucinous. Again, it changes a lot, but what will not change is urothelial is always double positive. Lung, thyroid, salivary gland is always 7 positive. Colorectal always 20 positive. Renal and prostate always both negative, right? So remember this. That should be more than enough rather than reading the entire table here. Fine. Okay. I'll go to the next question. The next question which I'm going to tell you is kind of a controversial one. I hope we will stay sane together and I'll come to a right answer. Fine. Comment on the answer, then I'll definitely discuss why it is controversial. Answer? Great, Chakravarti. Okay, fine, great. So some of you have answered D, some of you have answered C, fine. The below epithelium is not seen is the question, right? Okay, great. So looking at this microscopy of epithelium, can I say it is ciliated? It's ciliated, right? That is correct, that's for sure. Definitely it's a ciliated epithelium, right? It's not seen. I am not sure how many of you read the not seen part. If you have read the seen part alone, most of you must have written bronchus, right? It's definitely ciliated epithelium. Can I say bronchi will have ciliated columnar? Ciliated pseudostratified columnar. That I can rule out for sure, right? That's one thing which can be ruled out. I'll have ciliated columnar there. Oviduct is fallopian tubule. Can I say fallopian tubule will have cilia? It will push everything, right? Fallopian tubule should have cilia, right? So I can rule out option A as well. These two will have cilia, so that's not the right answer. So I'm left with two, ependyma and your epididymis. Epididymis, can I say they'll have stercocilia? Yes or no? Epididymis will have stercocilia, right? I'm sure you must have read them also. My only trouble is, by looking at this photograph, can I call it a cilia or stercocilia? Yes, Madam, it's required. I am coming to the answer, that's what. I cannot differentiate by looking at this photograph, this is stercocilia or a cilia. It's not possible for me to do that, right? It is cilia. Whenever I have cilia in microscopy, I don't know it's stercocilia or cilia. So can I say epididymis on a microscopy will look more or less the same because it has cilia, right? Ependyma will not have cilia. The predominant of the ependymal cells will not have cilia. So the below epithelium, which is a ciliated epithelium, is seen in oviduct, epididymis and bronchus, where it is not seen as ependyma. Fine, that's the right answer. Since it's a microscopy, I cannot differentiate cilia or stercocilia. If I have a question saying that ciliated epithelium is seen in all of the following except, then yes, epididymis could be an answer because epididymis has stercocilia and not cilia. Fine. Okay, great. This is a difficult one. We'll ignore this for now. Okay, look at this question. Answer this. Answer whatever comes to mind. D. Okay, A. I didn't expect this will have a difference of opinion between two options, D and A. Fine, we'll look through how it differs. Fine. It's an alcoholic male and that history is not important for me. I'm having an elevated erythrocyte sedimentation rate, right? The question is, which of the following is responsible for elevated ESR? Fine. So this is what the description of ESR is. Normally my erythrocytes are like this, right? What is the number of RBCs per ml of blood? If you guys can answer. In per ml of blood, how many RBCs do we have? There's a huge amount of RBCs, right? In per ml of blood, what is that? We have close to 4.55 million RBCs per cubic mm of blood, right? I have so many RBCs per drop of blood. In spite of that, my RBCs are not uniting with each other because they should clump. If you have millions of RBCs, they should definitely clump, right? They don't clump. It's 4.55 million of RBCs per ml of blood, right? The reason why they don't clump is because they have negative charge. They have same charge. Once they have same charge, even though they are very, very close together, they will repel themselves, right? So once they repel, so my blood can flow normally. This is very essential for my blood flow to happen. But when I take the same blood and keep it in a test tube, and I'm having a blood in a test tube, once it comes to this test tube, the flow is stopped. So the only person not letting them bind with each other is the charge. What happens is the fibrinogen. The fibrinogen neutralizes the charge. It will neutralize the charge on the RBCs. Once they neutralize the charge on the RBCs, can I say an RBC should sediment? They were not sedimenting or not coming in contact with each other because of the charge. Once they neutralize, automatically RBCs will sediment. Once they sediment, can I say the rate of sedimentation is nothing but ESR? I'm just going to calculate the rate of sedimentation. I call them an erythrocyte sedimentation rate. So there are two things here. There's a question which came once. It's a very old question. The charge which my fibrinogen neutralizes, that is called as an zeta potential. Okay, it is called as an zeta potential. That's a charge which is being neutralized by the fibrinogen, and the RBCs are made to clump, right? So this is the normal methodology of erythrocyte sedimentation rate. Now we're going back to the question. The question was asking Which of the following is responsible for the elevated ESR? The answer should be option D, fibrinogen. Fine. So someone commented rouleau, right? So rouleau formation is, can anyone tell me one condition where you see rouleau formation? One condition which all of us know, where rouleau formation is very common. What condition is that? It's a condition which comes to mind uniformly for all of us when we discuss about rouleau formation. What is that? Multiple myeloma, right? We always think of multiple myeloma whenever we have rouleau formation, right? So let's assume in multiple myeloma, no, rouleau formation always stands for multiple myeloma, right? So in multiple myeloma, what happens is you have something called as interleukin 6. Interleukin 6 is the one which increases the proliferation of multiple myeloma cells. Okay, that's a pathogenesis. So can I say interleukin 6 is also an acute phase reactant? Is that possible for me to say interleukin 6 is an acute phase reactant? It's definitely an acute phase reactant, right? So if it's an acute phase reactant, will interleukin 6 increase the levels of fibrinogen? It should. It should, right? So can I say the reason for multiple myeloma is again rouleau formation multiple myeloma is again fibrinogen? That's a final denominator. Fibrinogen determines everything. So if that is true, can I have any disease in my body which increases interleukin 6? Will it cause rouleau formation? Yes or no? It should cause rouleau formation? They have to cause, right? Rouleau formation should be there in every disease which increases your interleukin 6. So can a patient with sepsis or COVID pneumonia, can they have rouleau formation? Any person can have rouleau formation. If interleukin 6 is elevated due to any infection, rouleau formation is definitely a possibility, right? Just remember this alone. In a real life, when you see rouleau, always don't jump for multiple myeloma only. Every infection on the face of earth can cause rouleau formation, right? Okay, next one. Comment on this. I'll tell Bendomi. Comment on this, I'll tell. Okay, it's a very simple one, right? Good comments. Great. Mendomic, I'll take a question. C stands for C reactive protein, right? So C in C reactive protein stands for, it's actually the way it was derived from. It was actually the carbohydrate antibody of the capsule of pneumococcus. That's the where they derived the protein, or they discovered the protein. It's a carbohydrate antibody against the capsule of pneumococcus, capsular antigen. That's why it's mentioned as C. If you know C, that's more than enough, right? So they discovered the CRP, the protein, in first time in a pneumococcal pneumonia. Fine. I presume it's pneumococcus, fine. In pneumococcal pneumonia. So when they discovered that, they said that initially in pneumococcal pneumonia, I have a protein called a CRP, which is elevated. It's a reactive condition, it's getting elevated. But when they later on discovered more and learned more about CRP, they said that it's not pneumococcal pneumonia. Every inflammation in my body, be it your rheumatoid arthritis or your COVID or your simple streptococcus, the CRP will get elevated. So CRP is called as an acute phase reactant, that's all. Whenever CRP gets elevated, my only information is there is inflammation in the body. I don't know what is the cause of inflammation, but there's inflammation, that's all, right? So what we do CRP use these days is, can I say CRP is one of the factors which will determine which will predict the incidence of coronary artery disease. Can we use CRP as a marker to predict coronary artery disease? Is that statement correct? I can use them, right? It's a marker to predict your coronary artery disease. So how I'm going to use that is, let's assume a person is completely normal, no fever, no inflammation, no joint pain, nothing. Person is completely normal. So in that person, when I take the CRP levels, if the CRP levels is elevated, and if the patient has risk factor of diabetes, hypertensive, hyperlipidemia. Can I say this elevation in the CRP is due to inflammation of the blood vessels? Is that correlation correct? I can say that, right? So the significance of CRP is that. So when CRP is elevated in a person who is completely normal with the risk factors, I project the inflammation is there in the blood vessel wall. So that's atherosclerosis. So in future, the patient might have an MI. That's use of CRP now. And in inflammation like pneumonia cases, I can, your COVID cases, I can use that when CRP is more inflammation, more chance of lung damage, fine? That's about C in CRP and the significance of CRP, fine? Coming back to this, that's a very classical question, right? We'll try to what is this statement talking about? An alcoholic person with an eosinophilic intracellular inclusion, a eosinophilic intracellular deposit, which is nothing but your Mallory-Halen body, right? It's Mallory's Halen body. So Mallory-Halen body is nothing but about intermediate filament. To be specific, it's actually cytokeratin. It's cytokeratin 8 and cytokeratin 18. That's what gets deposited in your Mallory-Halen body, fine? So let's try and we'll see it's Mallory-Denk or a Mallory-Halen body, whatever we can call it, fine? So let's try and see if we can extrapolate something from this Mallory-Halen, Mallory-Denk being involved due to cytokeratin, fine? It's just due to cytokeratin. If you have a cell, any normal cell in the body, it has a shape. The shape is given by cytokeratin. The cytokeratin are called as cytoskeletal proteins or the intermediate filaments. They are like spokes of a wheel. They give the shape. So when a person consumes alcohol, the alcohol's aldehyde, the aldehyde is actually the problem. The acetaldehyde of the alcohol, once a person consumes, that acetaldehyde will go and destroy the cytokeratin. It destroys the protein. Can I say if a cell's protein is destroyed, which gives shape to the cell, will the cell collapse? Because that's the one that's holding the cell. It's like a tent and it's holding them. So first change is my cell collapses. It will not have the same shape. My nucleus is still there because there's no problem in the nucleus. What do you think will happen to the protein? The protein here is destroyed, right? If I have a protein which is getting destroyed, the color of the protein will be darker pink or lighter pink. It's a very common question. Or in other words, when I destroy a protein, will it become precipitated? Is that statement correct? Whenever a protein is destroyed, will it become precipitated? It should become precipitated, right? So what's going to happen here is I'll have a precipitated protein here. I have protein precipitate here. My protein will become precipitated here, right? So it becomes extremely dark and pink in color, right? So this dark pink structure, when Mallory discovered it, he was not sure what it is made of. So it's pink in color. Like someone said in the chat, if it's pink in color, what do I think of? Hyaline. So they called them Mallory's hyaline. That's all. It's Mallory's hyaline. I don't know what it is made of. Now, Deepti said that it's Mallory-Denk, right? Denk came years later and said, Mallory, it's not something I don't know. He only is the person who identified it's cytokeratin. So we give both of them credits. So we call them Mallory-Denk bodies. Fine. So this comes in MCQ in a different way. I'm just going to rephrase this. I'm sure you can easily answer that. Fine. I have a patient with a disease which is going to be very aggressive. If it's very aggressive, can I say that aggression can destroy this entire cell? A very forceful disease. Will it destroy the entire cell? If it destroys an entire cell, is there a possibility the Mallory-Hyaline or the Mallory-Denk bodies will be eaten by the macrophages because the cell membrane ruptures? Can I extrapolate that? That's definitely a possibility, right? That's definitely true. In other words, I can see this Mallory-Hyaline or Mallory-Denk bodies in almost every cause of hepatic damage. Whatever may be the cause, I'll see them. Where I don't see them is in conditions where you have very severe destruction, like fulminant hepatitis. In a patient with fulminant hepatitis, it's fulminant, it's very forceful. I don't see Mallory-Hyaline. Hemochromatosis. If you remember hemochromatosis, the mode of damage of hemochromatosis is due to free radicals. Free radical ruptures the cell. The most common method of free radical damage is lipid peroxidation. I don't see malarial Helen or malarial dengue, fine. So, and it's also said to not to be seen in secondary biliary cirrhosis. I don't know who created this, but it's not a problem for me. When I'm saying something is biliary cirrhosis, it's biliary. The bile duct will be primarily damaged, not the hepatocytes, right? So I'm not going to be worried about that. But hepatitis, fulminant, hemochromatosis, both are destructions of the liver, very forceful destructions of the liver, which will rupture this entirely, and my malarial hyaline or malarial dengue will be completely consumed. Fine. So again, it's not a fact. You can remember them with simple ideologies. Okay. Fine. Great. We'll call it a day today. Maybe by 10 in the night, I'll have a quick continuation of this, maybe half an hour or so. Is that okay? We'll group back by 10 p.m. and discuss a little bit more. Fine. If you have any doubts, come. You can ask now, or you can come back by 10 p.m. and you can ask me at that point of time as well. Fine. Or if you have any more doubts, you can ask me in the Telegram or Instagram groups. I'll definitely be able to answer you. Thank you for your time. Thank you. Bye-bye. Thank you for your patient listening. Bye.